So I'll really be building on previous remarks from Dr. Grumbach as well as from Dr. Kaiser. And I want to start out, again, just showing a panoply of different ways that people have defined access through the years. This list is slightly different from Dr. Kaiser's list. I threw in a couple of other approaches, including the approach from Dr. Donabedian, focusing on the ease with which care is initiated and maintained, as well as the classic paper by Penchasky and Thomas, referring to the fit between the patient and the healthcare system. So what you see as you look at these different conceptual approaches to access is that they're rather difficult to measure, or different approaches might be measured in different ways. So, for example, the IOM definition from 1993 refers to the timely use of health services to achieve the best health outcomes. So it implies that we're focused on access to what? That we don't care if we're providing access to lousy care, if we're providing access to ineffective care. We want to provide access to care that improves health outcomes. And similarly, you can see in the last definition, I've italicized the concept that there is this balance between the supply and the demand for care, that certain people need more care than others, and therefore we want to ensure that we're providing access in proportion to what people's needs are. And that again gets back to the issue of equity that Dr. Grumbach addressed, that we have to make sure that we're providing access to the most vulnerable members of our population that have the greatest burden of chronic illness. Next slide. So obviously the VA has made a strong start here at measuring access, and this is the accesstocare.va website. And the wonderful thing about this is that you can readily drill into information about your local VA facility, and you can see information about wait times for different types of services. How quickly can my VA facility see me? And you can see some satisfaction or patient experience measures from the SHEP survey about how satisfied veterans are with their care in my facility. But next slide. I'm going to argue that that's really not enough. And one of the key reasons it's not enough really gets back to Dr. Grumbach's Bauhaus point. I'm not as clever about architectural metaphors as he is, but I'm saying the same thing, which is the fundamental purpose of quality measurement is to drive and inform quality improvement. That's why we do what we do. So the corollary of that is that measures are only worthwhile if they drive or inform true improvement in quality. So we really have to consider whether and how the measures will be used. Now, that use could be at a high level by Congress, by policymakers. That use could be by consumers choosing among different sites where they could seek care, or it could be by providers and managers within the healthcare system. But somehow there has to be a practical use of the measure to drive and inform quality improvement. Next. So the other thing to keep in mind is that the design and implementation of measures involves a life cycle. It involves a feedback loop. And I know that Mary Barton at NCQA has a feedback loop that looks something like this. AHRQ does, CMS does, PCPI does. All the organizations involved in measure development have something that looks like this, because we start with theoretical concepts, and then we select and define indicators to operationalize, to measure those concepts. We collect data, we analyze the data, we review the data, then we have to interpret the results and decide what to do about the results, that theme of actionability that you've heard from both of the previous speakers. We use that information to guide our decision-making, and that leads to changes in our theoretical concepts. We then decide, well, this wasn't really the right thing to measure. We should measure something else instead. So we continually refine our measures. So although it's wonderful the VA has started with these measures of wait time, we know over time that these measures can be gained. We know that they provide a limited view. And so as we go through this feedback loop, we understand that we need to revise these measures, we need to expand these measures and incorporate new measures into the Access portfolio. Next. I also find it very helpful as a practicing clinician to go back to Avitas Donabedian's classic framework of structure, process, and outcomes. And we've already heard from John Fortney that Donabedian was careful to say that access per se is not part of his definition of quality. But the point is that it is closely related, and it's closely related at all three stages. So we can talk about access in terms of structures of care that promote and enable access. We can talk about the processes of care of how we actually deliver access. And we can talk about the results of providing access. Again, recognizing that access is meaningless unless we're providing access to effective services in a timely manner, leading to better health outcomes. Next. So this is, again, borrowing from John Fortney's framework, pointing out, I think there's some consistency in our approach here, that he's emphasized the actual access measures, such as wait times that we've been talking about. He's also emphasized the importance of veteran perceptions. But as you can see in the right half here, these concepts have to be related to technical and interpersonal aspects of quality, as well as outcomes. And we presume that they're related through enhanced utilization of care, particularly enhanced utilization of care that's likely to be more effective. Next slide. So here's an example. And again, I've sort of aligned the Donabedian framework with two of the traditional IOM domains that relate to access. So the timeliness domain. So we have structural features such as the organizational policy on scheduling urgent appointments. And we know that many of the VISNs, many of the health systems have implemented immediate access programs to facilitate scheduling of urgent appointments. That's a structural improvement or feature. Then we measure the process. What is actually the wait time for urgent care appointments? And that may require secret shopper surveys. You may be able to ascertain it from the electronic health records themselves, although, as we know, there are some limitations there. But ultimately, we'd like to see that providing better access to urgent care leads to fewer potentially avoidable hospitalizations or ED visits for chronic conditions that are amenable to ambulatory management, like asthma and heart failure. So we see this continuum of different types of measures that really address timeliness as a feature of access. Similarly, if we're talking about linguistic access, we can look at whether a system of care provides adequate interpreting services, whether those services are available, but we can also look at whether those services are actually used in patients who have indicated their desire, their preference to have an interpreter involved in their care. And then finally, we can bring that to the equity angle that if those interpreting services are effective, they should be reducing disparities in the processes and outcomes of care according to patients' primary language. And that's a way of looking at the impact of the efforts that we've made to improve access. Next. So from the sort of geeky perspective of looking at the performance characteristics of measures, when we discuss these concepts at NQF and elsewhere, we talk a lot about the reliability and validity of the measures. And Mary Barton has discussed already a little bit, and I'm going to drill into a little bit more detail here. So when we talk about reliability, we're really talking about the magnitude of measurement error in our observed measurements in comparison with the inherent variability in the true level of the quantity of interest. And this is the concept of signal to noise, that we're comparing the signal that we get from the measure, which represents the true variation in the phenomena of interest, with the random variation or the noise. So if we have a reliable measure, then the random measurement error is small compared with the true differences among the units, and this allows us to distinguish the units and to identify the units that are actually providing better access than others. Now, this is a little bit different concept from the concept of reproducibility or stability, which focuses on variation under changing conditions. And this is the classic sort of test-retest approach where you look at the performance of a healthcare organization over two different time periods. And this is based on the notion that the changing temporal conditions are unlikely to substantially affect the true values of the construct of interest. So it's a little bit different concept. Sometimes we're interested in both concepts, especially when we're using old data to help people make decisions today about where to seek care when they have a choice. So we have to keep in mind that a measure may have high reliability but low stability, or conceivably vice versa. Next slide. So validity is really the extent to which a measure achieves the purpose for which it is intended, or measures the true state of what it purports to measure. And here we're talking about access to care. So just as a reliable measure has relatively low random error, a valid measure has relatively low systematic error or bias. My key point here is that the validity of a performance score is linked to the decisions that users of the score would make based on the scores presented to them. So validity really comes from and is inherently linked to the concept of function, how the measure is being used. It is the use of the measure that defines the validity of the measure. At the bottom half, we have the classic bullseye diagram of different types of approaches that might be reliable but not valid, or valid but not reliable, or both. Next slide. So how do we assess validity in practice? How do we decide whether our access measures are valid? Well, of course, the fundamental approach that I think others have alluded to, particularly in John Fortney's presentation, is really about content validity. How do our clients, how do our stakeholders, how do veterans view the content of the access measure? Is the measure actually telling veterans something that's important to them, that's meaningful in terms of the veteran's experience with care? So this is important, it's foundational. But I will argue that it is not sufficient. And I think this argument is also reflected in the way NQF evaluates measures. We also have to look at what we might call the criterion or construct validity of measures. And I don't want to get hung up in semantics because different people use these terms slightly different ways. But when we talk about criterion validity, we often talk about how well a measure predicts important future outcomes, such as, for example, potentially avoidable admissions or improvements in diabetic care with reduced hemoglobin A1C or improved asthma control. So we can look at how well an access measure predicts what we know matters to patients and to populations down the road. We could also look at how an access measure correlates with other measures that are conceptually related. Again, going back to Donabedian's framework, to Fortney's framework. If these frameworks are valid, then we should be able to show that different measures are correlated with each other in ways that improve our confidence in both of those measures. Next slide. So I'm going to cite, again, an example that Kevin's already alluded to from Augustine's work, basically showing that from the SHEP survey, the patient's, the respondent's endorsement of always being able to get the care you needed after hours was clearly associated with hospitalizations for ambulatory care sensitive conditions in the subsequent year. Next slide. Similarly, the same group showed that the survey response to how many days people usually have to wait for an appointment when they needed care right away was associated with reliance on VHA versus private sector care in the subsequent year. Next slide. So my conclusions from these examples is that as we consider measures of access, we should really be thinking about driving and informing quality improvement. That's what it's all about. All measures are part of a life cycle of measurement, improvement, refinement, and potentially retirement if we achieve the objectives, if we get topped out, so to speak. We should consider integrating access into classic frameworks, such as Donabedian's framework. We should assess measures for reliability at the level of the accountable unit, and we should assess measures for validity, and we should be prepared to put more weight and more resources into measures that are more valid. Again, measures that are more helpful in terms of informing us about the type of care that will ultimately improve outcomes for veterans. So thank you very much, and I'll turn it back over.